Welcome everyone to this exciting and relatively new event. This is the next episode of the Journal of Clinical Anesthesia monthly podcast where we feature noteworthy articles from each issue. I'm student Dr. Ashley Moore, Assistant Social Media Editor for the Journal, and your host for today's interview. I would like to offer a huge welcome to Dr. Bernd in the Department of Anesthesiology. He practices over at the University Medical Center in Hamburg in Germany and also in Cleveland, Ohio. He is one of the authors of an article from our upcoming January 2025 issue titled Personalized Perioperative Blood Pressure Management in Patients Having Major Non-Cardiac Surgery, a bicentric pilot randomized trial. Thank you so much for taking the time to talk with me today.
Thank you very much for having me.
Okay. So we'll go ahead and get things rolling and start off this interview by asking, could you briefly summarize your study for our listeners and specifically tell us more about what were the main factors considered when designing the bicentric pilot randomized trial for personalized perioperative blood pressure management?
Sure. So in the last decade, we learned that intraoperative hypotension is associated with organ injury. We know that from many observational cohort studies showing consistently that there is an association between low blood pressures during surgery and postoperative organ injury. And therefore, it is currently recommended that we keep mean arterial pressure above the population harm threshold of about 60 to 65 millimeters of mercury during surgery. But I think it's still unknown whether individual patients require higher blood pressures or whether this one-size-fits-all approach of keeping mean arterial pressure above 60 to 65 is safe for every single patient. We in our research group assume that intraoperative hypertension harm thresholds differ among different individuals and that blood pressure thresholds or blood pressure targets during surgery should also be individually defined. And we therefore have the overall hypothesis that individualized perioperative blood pressure management, maintaining intraoperative mean arterial pressures above a preoperative baseline pressure, reduces organ injury compared to a one-size-fits-all approach of just keeping mean arterial pressure above 65 in patients having major non-cardiac surgery. But before we are going to test our hypothesis in a large-scale multi-center trial, we wanted to perform this pilot trial and we wanted to determine three main things. And the first thing is that we wanted to know if performing preoperative automated blood pressure monitoring during the nighttime is feasible and whether we can use these automated preoperative measurements to calculate personalized intraoperative mean arterial pressure targets. Second, we wanted to know in what proportion of patients the preoperative nighttime mean arterial pressure clinically meaningfully differs from a mean arterial pressure of 65, which is the population harm thresholds. And third, we wanted to know if maintaining intraoperative mean arterial pressure above the preoperative nighttime mean arterial pressure is feasible during major non-cardiac surgery.
Excellent. I love to hear that. Thank you so much for explaining that, Dr. Sagal. After reading your article, we would really like to know what challenges did the team encounter when tailoring blood pressure management for individual patients?
Yeah, excellent question. Well, the good news is there were no major roadblocks, no major challenges that we did encounter that would have suggested that a major multi-center trial is not feasible. So specifically, the preoperative automated nighttime blood pressure monitoring to calculate the individualized intraoperative targets was possible in more than 90% of all patients, specifically 93% of patients. And this was very important when conceptualizing the large trial, the measurements were also well tolerated by the patients, as in many other previous own studies using automated blood pressure monitoring. So at the end of the day, we concluded that there are no major challenges that would suggest that we cannot proceed and test our hypothesis in a large multi-center setting.
Excellent. That's wonderful, Dr. Sagal. What were the primary clinical outcomes observed in patients who received personalized perioperative blood pressure management?
Yeah, well, the most important finding is that the preoperative mean nighttime mean arterial pressure varied substantially among individuals, because this is kind of justifying our hypothesis that intraoperative harm thresholds may also differ, and that we should presumably use individualized targets during surgery. So there was a substantial range. We didn't go below a blood pressure of 65 in the intervention group, so the lowest intraoperative target was 65, but some of the patients never have low blood pressures, not even during the nighttime when blood pressure usually dips. So the range was between 65 and 123 millimeters of mercury. So I guess you agree that this is substantially higher than 65. The median preoperative mean nighttime mean arterial pressure was around 90, so it was 88 millimeters of mercury. And we a priori decided to consider a difference of more than plus minus 10 millimeters of mercury as clinically meaningful a difference between our target blood pressure and blood pressure of 65. And in 85% of our patients, the preoperative mean nighttime mean arterial pressure clinically meaningfully differed from this population harm threshold, and the mean difference was 22 millimeters of mercury. So from that, we not only concluded that the preoperative measurement is possible, but also that using individualized targets will result in substantially different blood pressures than just using the population target of 65.
Amazing, amazing, amazing. Can you elaborate a little bit more on how might this pilot study inform larger multi-center trials in the future?
Yeah, we are already running our multi-center trial, and in this ongoing multi-center trial, the individualized intraoperative mean arterial pressure intervention thresholds are defined the same way as in the pilot trial. The inclusion criteria are also very similar, but in future trials, I would restrict patient inclusion to patients who have arterial hypertension in the preoperative measurement, simply as a strategy to enrich the population and to restrict the population to patients who will most likely benefit from higher individualized targets. So we do not do that in the ongoing multi-center trial, but we are already planning a follow-up study, and in that study we will definitely restrict our inclusion criteria to patients with chronic arterial hypertension.
That's a great idea. I think that will show amazing results as well. So again, thank you so much, Dr. Saugel. Your research and findings have definitely influenced me, in my opinion, on personalized perioperative blood pressure management in patients having these major non-cardiac surgeries. And also your research has brought awareness to a very important subject, and I'm sure you have influenced many anesthesiologists all over to consider this model in the future. Thank you for taking the time to talk with me today and allowing our audience to have a deeper and clearer understanding of this matter. To all of our viewers and listeners, please be sure to read the article in the Journal of Clinical Anesthesia January 2025 issue, and also be sure to follow our social media sites on X, formerly known as Twitter, Instagram, and Facebook at Journal of Clinical Anesthesia. Again, thank you, Dr. Saugel. I wish you and your team all the best.
Thank you very much.